Today we are presenting a fenestrated repair of a type 3 thoracoabdominal aortic aneurysm in a patient with Marfan's disease and a degenerated chronic aortic dissection. PR is a 62-year-old male with Marfan's disease and a history of a type A aortic dissection who was referred with an enlarging type 3 thoracoabdominal aortic aneurysm. In 2005, he suffered from an acute type A aortic dissection requiring aortic root replacement and a mechanical valve. Subsequently, in 2006, he was found to have degeneration of his aortic arch, necessitating an arch repair with an elephant trunk. This was complicated by a left hemispheric stroke with right arm weakness. In 2007, he required a thoracotomy for repair of his descending thoracic aorta. In spring of 2016, he was referred to us with aneurysmal degeneration of a type 3 thoracoda 6.3 centimeters. He was unwilling to undergo any further open surgery after his previous experiences. We offered him either open thoracoabdominal repair or fenestrated repair. He opted for fenestrated repair due to his experience with multiple previous open aortic surgeries. His preoperative CT angiogram shows evidence of chronic dissection extending up into the innominate artery. As we scroll down, there is chronic dissection and aneurysmal degeneration of the thoracic aorta below his previous repairs. The maximal aortic diameter in the descending thoracic aorta is 6.3 centimeters. The celiac artery comes off of the false lumen. There is a septum fenestration 1 centimeter proximal to the orifice. The SMA comes off of the true lumen. The right renal artery comes off of the false lumen with its septum fenestration at the same level. The left renal artery comes off of the true lumen. The dissection extends into the right common iliac artery, and the left iliac artery comes off of the true lumen. From the axial images, 3D reconstruction software was utilized. This allows for accurate centerline measurement and precise planning for a custom fenestrated device. A 4-vessel fenestrated custom device was ordered. The operative plan consisted of deploying a TEVAR, followed by placement of the custom 4-vessel fenestrated device with serial deployment. The target fenestrations are cannulated and stent grafts placed into the visceral target arteries. A bifurcate graft below was subsequently deployed, followed by iliac extensions. The decision was made to use a preloaded device that will allow for snaring of a preloaded through-and-through wire for increased ease of cannulation of the celiac and SMA from above. A preoperative 3D spin is done. This allows us to align anatomic landmarks and minimize contrast utilization throughout the case. We start the case with bilateral groin exposures and a right axillary artery exposure. After the TEVAR is deployed, the main body of the fenestrated graft is advanced via the left common femoral artery. The fenestrated component is deployed until the celiac fenestration opens. The rest of the graft remains constrained. This allows for adequate room outside the graft within the true lumen to ease in cannulation. Snaring of the through-and-through preloaded wire from above will serve to guide sheaths from the axillary artery into the top of the fenestrated graft and out the fenestrations. From the right axillary artery, a sheath is advanced over the preloaded through-and-through wire out the celiac fenestration, and the celiac artery is cannulated. In the same manner, from the right axillary artery, a sheath is advanced over the preloaded through-and-through wire out the SMA fenestration, and the SMA is cannulated. The remainder of the graft is then deployed. The graft is cannulated from below from the right common femoral artery. An SMA bridging stent graft is deployed, and a selective SMA angiogram is performed. A celiac bridging stent graft is deployed, and a selective celiac angiogram is done. The left renal bridging stent graft is deployed, and a selective left renal angiogram is performed. The right renal stent graft is deployed, and the angiogram demonstrates an endoleak due to inadequate length of the bridging stent graft. After the right renal stent graft is extended, the renal angiogram demonstrates an adequate seal, with no remaining endoleak. The bifurcated endograft is then advanced via the left common femoral artery into the fenestrated graft. The bifurcated graft is then deployed in the standard fashion to the contralateral gate. The contralateral gate is encannulated with a glide wire and a directional catheter. The right hypogastric artery is then identified, and the right iliac limb extension is advanced and deployed. The left hypogastric artery is identified, and the left iliac limb extension is advanced and deployed. We then deployed an Amplatzer plug into the false lumen of the right common iliac artery to prevent a type 1B endoleak. At the end of the case, a completion 3D spin was performed. This obviated the need for completion angiogram. At 2 months, the postoperative CT shows a persistent dissection extending into the innominate artery. The TEVAR and FEVAR are appropriately placed without evidence of a type 1A endoleak. The false lumen of the dissection flap has thrombosed. All bridging stent grafts are widely patent without type 3 endoleaks. The false lumen at the right common iliac artery is also thrombosed without a type 1B endoleak. At 2 months, the 3D spin reconstruction also depicts complete exclusion of the degenerated segments. Thank you very much.